video. This is Kismet. It's destiny. We are back here. We're back. I'm so honored to be able to introduce you as the host for the final hour of this marathon. Everyone knows who Jim Pickett is, but I'll just say senior advisor at FAAP, directs the choice agenda, policy leader, and most importantly, I think the official winner of the hostess with the mostest.
I don't know. I think you and I might have to do a runoff, but thank you. This is, you wouldn't believe it necessarily, but I ran some marathons in my past. And this last home stretch is the exhilarating part.
Yes.
There's some peaks and valleys, but here we are. We're exhilaration, and we have some really great talks coming up. So thank you so much, Oni. It was great to host with you yesterday and to see you right now.
Bye, Jim. Give me the baton.
Thank you. So I am so incredibly delighted to introduce our first speaker, who is someone I have known since infancy, it seems like for decades, someone who has been an honorary spouse for decades, and talking about a really, really important topic, COVID. JD Davids, I am so honored to introduce you. What a delight to see you. And I want to just thank you before I turn it over to you for really carrying the torch on COVID advocacy and long COVID advocacy. You have been one of the precious few folks who have been doing this work. And I know how hard it's been. And I just want to say how much I love and appreciate you for that. So with that said, let's hear what you have to say.
Thanks, Jim. Thanks to AVAC. Thanks to everybody who's doing this live stream and everyone who's continuing to fight for the things we need to save and improve lives around the world. I'm also happy to be one of the co-authors of AVAC's No Data, No More manifesto for trans inclusion and HIV prevention research. We need that now more than ever, that trans people are being rendered invisible by the Trump administration and forces worldwide. So with all the calls to action that people are acting on today, I encourage you to be trans specific. And whenever you're calling and asking for anything, add in the trans people, because we're being left out. And in the United States, if you are someone who got any trans care or changed any documents, you're on a list and they're going to do something with that list. So please be ready to mobilize at a moment's notice for trans lives, because it's never not needed. I'm happy to be here today. Thank you to the host again. I'm a multi-partner PrEP user living with long COVID and other complex chronic conditions. And also one of my partners was diagnosed with advanced HIV disease in the hospital just 2 years ago in the US and had terrible care. So there's things hit me personally and as an activist in HIV for many years. But I'm here also to talk about long COVID. COVID is a chronic condition. And in the scheme of things over the coming decades, the biggest toll from COVID is going to be chronic disease. If we think about it, HIV disease is actually long HIV, we could say. There's a virus that's about 40% of people, when they get HIV, get like a flu or something, right? And they get better. And then if not treated, will have disease and illness and potentially death, down the line. With COVID, it looks like about 6% in the long term will have a frequently disabling illness that can have a lot of different facets and manifestations, just like untreated HIV disease. That's called long COVID, which is a name that was made up by people with long COVID who were not getting better in the 2 weeks that they were predicted to get better if they survived initial COVID. Today, there's 400 million people around the world, including children, adults, and elders who have long COVID, the vast majority of whom do not know it and who are being left to survive or perish on their own. And people with HIV are 2 to 4 times as likely to get long COVID. Why is that? Because those of us who are already disabled or chronically ill are most likely to get long COVID. The highest rates, at least in the United States, of long COVID are in trans people. And among trans people, we see in research by Tonya Poteet and the CFAR and other researchers, the highest rates among trans people may be among people who were assigned female at birth, regardless of their current hormone use or status. So what is long COVID? It's too much for me to explain right now. But Long COVID Justice, longcovidjustice.org, has an excellent series called Long COVID Essentials, currently in English and Spanish, other translations possible with your assistance, that goes through the basics of long COVID and what to do if you or others you love think you may have long COVID. It's called the Long COVID Essentials. And Gabriel San Emeterio in the US is sponsoring, through Long COVID Justice, a support group through the HIV Complexities Project with support from ViiV Healthcare. That's a support group for people living with HIV and other chronic conditions at the same time, whether you have chronic fatigue, chronic pain, or comorbidities like diabetes or other things like long COVID. We encourage you to join Gabriel's group to support yourselves and others. What to do if you have COVID? Every time someone gets COVID, they're at new risk of long COVID. And that means what could be permanent chronic conditions from triggered by COVID itself. Vaccination for COVID can decrease but not eliminate risk of long COVID. Taking COVID antivirals, particularly Paxlovid is where most of the data is, may help lower rates of long COVID. Also metformin, which is a diabetes drug, when people took it for 2 weeks, they were less likely to get long COVID. However, COVID prevention works. Masks work. Masks were invented to protect people from, industrial toxins and other things, and they work. People don't get the toxins if they wear them. But you need to have KN95 or N95 masks, or the masks that work. We need these to be distributed by HIV organizations. But we know, unfortunately, it seems like sometimes there's stigma about being sick in the HIV community. It makes sense because people in our community have experienced tremendous discrimination and bias from fears of illness, from fears of disability. But that's why we should be extra careful to not perpetuate the stigma and bias against disabled and chronically ill people from within the HIV community itself. So what am I asked today is whether you are running HIV programs, whether you're doing research or outreach, what are you doing to include people who are chronically ill, multiply chronically ill and disabled, who are living with HIV in your research? Are we only including sort of the most able-bodied of people with HIV in the research? We know that's not everybody. I also want to talk a bit about what I'm sure people have been talking about, the importance of patient-led and community-led involvement in research. It wasn't until I started being active on long COVID that I learned about the National Health Council, nationalhealthcouncil.org's fair market value calculator, which is part of a suite of patient compensation tools, which says how much should patients and people with subject matter expertise be paid for our involvement in research design, and community programming. So check that out. Also, a group that I'm happy to be a part of, the Patient-Led Research Collaborative, PLRC, has a patient-led research scorecard that we developed with the Council of Medical Specialty Societies in collaboration that takes the form of scorecards to evaluate how effective a patient group and research partner collaboration which will be conducting truly patient-led research. So please check that out. Patient-Led Research Collaborative is a group of people living with long COVID, in some ways modeled on what we've done in the HIV community. And by May 2020, we came out with the first data showing the existence of long COVID, which didn't even have a name at that point. And that's now one of the most downloaded preprints in history. But along the way, we see, just like we did in HIV, when people with long COVID are involved in the research, the questions are sharper, the results are better and more useful, and the dissemination of findings is more robust. So consult with people with long COVID, consult with people with HIV, make us your partners. We are the key. We are not the problem. We are the answers. In the UK, there's Long COVID Support UK, has a research involvement consultancy. Whether you're looking for patient and public involvement or to recruit for the study, you can reach out to them. And since they started this last June, they've already assisted about 15 clients. So we're here to help. And I just wanted to end with talking about, I have a very high bar for patient involvement. As a member of the community constituency group of the AIDS clinical trials group when I was about 23 years old, which was quite some time ago, the AIDS clinical trials group we elected our own members for the community constituency group. We had elected 2 representatives to the executive board of the AIDS clinical trials group, and we were involved on every single committee, on every single protocol team. I went on to become a member of the strategic working group of the Division of AIDS, giving input into cross-cutting issues for all the intramural HIV networks around the world. and they had to come to us for any research over $25 million. So that was an incredible experience, but it's an experience that should not be atypical. We should have this level of input and control as patients and community representatives at every level. So if you are a community leader and you're being asked to give input, the first thing to find out is, how much power do you have? Are you just supposed to rubber stamp things? Are you on equal footing with the so-called professionals who are working on this committee or body? What do you have voting power? Are you just advisory? How many times have you listened to advice or ignored advice? And then think about whether you want to be advisory. What are your actual rights and responsibilities? And is this something that is going to help you and support you in your development and your health? Or is this something that's going to deplete you, frustrate you, and ultimately harm you and potentially your community? So I'm always happy to talk about this stuff. And reach out, find me at the Cranky Queer on various social media, find me through Jim or AVAC. And thank you so much for all that you're doing, and let's keep fighting together.
All right, thank you. The studio audience go. So we have some time to chat, my friend. If folks have questions or comments, please put them in the chat. But I have JD and I could talk for hours, and I think there's lots of stuff we could dig into here. Where I think I want to start is, I think you've been very. I just want to hear your critique on what the HIV sector can be doing better in terms of HIV, in terms of COVID engagement. I know this has been a frustration. I know it would seem like we were all hot on it for a minute, and then a lot of the interest faded away. Yet people with COVID and long COVID persist, and the challenges with COVID persist. So what can we be doing better in the HIV community? Give us some critique and some guidance.
You know,
and more than advice, we don't need, give us some marching orders.
Well, as I learned from the HIV community, and particularly I'm thinking back to what I learned from Rebecca Dennison and World and Women Living with HIV about what it means to center people in your efforts and what it means to marginalize people. And at that time, I remember hearing Rebecca in 1992, was it, 93, at the International AIDS Conference in Berlin, talking about how women were being asked to share their painful experiences that then went into grant proposals or research proposals that they were locked out of. So I want to credit my sort of foreparents in this struggle, who I've always tried to honor through my work as someone who's not living with HIV. When we look at who can and can't afford to be in places where airborne pathogens are spreading, we are looking at, unfortunately, not just creating bias against people who have greater vulnerability in the HIV community, but actually making the community sicker. We didn't know in the past or acknowledge how much some conditions are transmitted through air. And there's been really confusing information about COVID. But the truth is that COVID smoke in the air. It's not about particles that somehow drop to the ground at 5.5 feet and you're safe 6 feet away. Sometimes if you're in the back of the room, the air system is taking the air from the front from a speaker and dumping it right to the back of the room. We don't know. So masks work. I know that people have had traumatic experiences. It's been very hard, and some people have had so much loss from COVID that it can be hard to put the mask back on. But when we're inside together, like we recently were, when I got to facilitate the retreat, the planning retreat for the steering committee of the US Caucus of People Living with HIV, wearing a mask keeps each other safe and allows people to be in the room who otherwise could not afford to be there. We also can bring in air filtration, which cycles through the air in the room to take out pathogens. And that means that people aren't coming home from conferences and meetings sick, because some of the people who come home from meetings and conferences sick are going to stay sick. Or we know now that people who get COVID within the next year have an elevated risk of things like stroke, heart attacks, aneurysms. So this may seem unrelated when all these younger people are dying of these conditions in the middle of the night, but this is a preventable tragedy that's been politicized. So protecting one another is within the ethics of the HIV community. And when we say nothing about us without us, What does it mean when we're subjecting people to illness and further disability to be in the room that we say it's so important for you to be in the table? It's so important for you to be in the room. As someone with a genetic immune suppression, I came home from so many HIV meetings sick through the years. And I don't do that anymore because now I'm masked, but that's part of why now I have chronic conditions because of my HIV advocacy that I did as an immune suppressed person. So how do we protect one another? Is really the question. Do we want to protect one another, or are we just about one condition?
Right. And are we going to be just performative about that and kind of say the right things and then just go ahead and take actions that belie that? And it's such a good point. I think for all the many years of going to conferences up until recently, there was not one conference that I went to that I did not come home with a cold. Sick. I often got sick at the conference. I've been sick in so many different countries in this world. Mm-hmm. And can we talk about making masks can be fun. We can brand them. We can make them cute. We can have cute HIV prevention messages on them about PrEP. We can do something with the mask. So I think we need to be pushing masks more again. And I really appreciate your advocacy on that.
Thank you. And we can also, when possible, meet outside, unless people are packed in very tight outside, like at a protest. It generally is pretty safe to be like outside in the air because it dissipates very quickly. And let's be honest, COVID prevention is harder than HIV prevention. HIV prevention is not easy. But, I could go out and have a date with someone and choose whether or not or how to protect myself sexually, but I'm not going to come home and breathe it onto grandma. You know what I'm saying? So let's not minimize how hard it is. But in the world we're in now with wildfires, with, a lot of so-called natural disasters that are happening because of ecological collapse, we are going to need to learn to keep each other safe in terms of these sort of environmental risks. And COVID and airborne viruses are environmental risks, and many of them go chronic. Epstein-Barr is a very common virus, and it's behind a lot of things, probably like multiple sclerosis, we now know. It causes mono, which is sort of trivialized as a kissing disease. But in adolescents, about 10% of Epstein-Barr infections go chronic. And what that means is lifelong, potentially, fatigue, brain fog, trouble thinking, increased risk of autoimmune and other conditions. So this stuff is not trivial, right? And we know that kissing doesn't kill when it comes to HIV, but it does transmit stuff. And we need to have a higher standard for health, or we're going to be sort of disabling a whole new generation of people who are going to have lifelong health struggles. And if people have HIV, it's more likely that this stuff may become chronic. Even if people are on treatment, there's issues like inflammation we now know and other things that can happen. So it's imperative that we keep each other as healthy as possible and take care of one another. About 25% of people with long COVID say it's severely disabling. People cannot leave their bed or they cannot leave their home. And there's virtually no support and virtually no help for people with long COVID. So please talk about it. Please ask after your friends, family, and loved ones who aren't doing well and help. If people have fatigue, there are some over-the-counter treatments that may help for some of the conditions with long COVID. Look at the Long COVID Essentials Project from Long COVID Justice and fight for long COVID research in people with HIV, trans people, and others.
JD, thank you so much for your work. I want to just highlight a quick comment from the chat from the HIV Justice Network. And they are also thanking you, JD. We need more meetings or conferences that ensure masking, clean air, and outdoor dining as the norm. We managed it last year with our HIV Justice Worldwide convening in Spain. So there's some good templates. There's some good models to follow. Thank you all for doing that work. JD, thank you for being such an important, often it sometimes seems maybe to me as a lone wolf out there making these statements. I know you're in community, there's it's growing, but I feel like we need to be giving so much more attention to all the things you're talking about. And I just so appreciate all the work you're doing to sound the alarm and keep us accountable.
Thank you.
So thank you, JD. And now we're going to do a quick testimonial, I believe, from Vincent.
Hi, my name is Vincent Curie. I'm the HIV vaccines product development team lead at FAAP. Science alone is not enough. when you look at the gains that have been made in the response to HIV, these have been made possible by commitments from governments, funding agencies, healthcare professionals, communities, scientists, all coming together to work towards the same goal. When thinking about HIV vaccine development, we do need sustained investment to maintain resources necessary for the research to take place, continued involvement by policymakers and governments in driving the field forward, and also involvement of communities. For everyone who's watching, I would say we are in sight of a vaccine that could effectively help us end the HIV pandemic within our lifetime.
Thank you very much for those comments from Vincent. And a reminder, we're still collecting stories. So if you would like to share your story, you can go ahead, go to our website, and there's a place where you can drop that there. And it's popping up on the screen, just like magic. I'm excited to bring our next guest forward. Grace John-Stewart, coming from the other side of the country, University of Washington, is going to be talking about children who have been impacted by HIV in utero. I'm going to turn it over to you, Grace. Thank you so much for being here with us today.
Thank you. I'm so glad to be here and happy to be presenting. I hope my slides are visible.
Grace, I think you want to get into slideshow mode. We're seeing your, yeah.
Can you see me in slideshow mode now?
It is, but we're also seeing your next slides and your previous slides.
Okay, let me see what I can do about that. I see something different on mine. Let me see if I can control it from. How about now?
It is still the same.
Okay, let me just try one more thing. I'll get back to.
If you do the slideshow and then that far left green little arrow.
How about that?
We got it. Thank you.
Okay,
beautiful.
Sorry about that. Does it move now? Can you see the next slide when I move it?
Yes, it's gorgeous.
Okay, let me just go back, although it seems like I'm having a little struggle getting this to move.
Actually, just to jump in really quickly, Grace, I'm sharing your slides, so if you just want to...
Okay, let's just do that. Okay.
Thank you, Levi.
Sorry. Okay, Levi, thank you. Can we start with the first slide again? Yeah, so this is what I'm going to be talking about today is looking at kids who had exposure to HIV but escaped HIV. And so these are kids that have HIV exposure. We often call them children with HIV exposure but not infection, or CHEU. Next slide. So I think there was a talk previously in this great session just talking about how without treatment during pregnancy and the birth period, there's a high risk of infants acquiring infection. It's somewhere between 20 to 45% of infants will acquire HIV if they don't get treated. And this occurs when the virus crosses the placenta, during the delivery process, and during breastfeeding. Next slide. So we also know that with treatment, there's this dramatic reduction in transmission. So before treatment, the risks I mentioned were as high as over 40%. And now with treatment, it's well below 1%. And we can almost guarantee that a child will not acquire HIV infection. Next slide. And so this has resulted in a lot of progress throughout the world in decreasing child infections. You can see in this curve to the right that the rates, the number of children acquiring infection every year went from over 300,000 per year to 150,000 per year. And it's estimated in the last 14 years, about 4.4 million children had averted infections. Next slide. So in this slide, you can just see that in the dark green, that's that decrease in children acquiring HIV. At the same time, there is a parallel increase in children who did not acquire HIV but were exposed to HIV in utero. Next slide. And so it's estimated there's about 16 million children who don't have HIV but were exposed to HIV or to antiretroviral therapy during their in utero period. Next slide. And if you look at certain countries, in this, there are some countries where 1 in 3 or 1 in 4 babies were born with exposure to HIV, even though they themselves did not acquire HIV infection. Next slide. So the question is, could this exposure without HIV infection influence the health outcomes of children? And it's possible. They have exposure to the virus while in utero. They have exposure to the changes in maternal immune changes due to HIV, and they have exposure to drug regimens during pregnancy. Next slide. And there have been many studies suggesting and showing that they have increased mortality, hospitalizations, and next animation, decreased growth, and finally, decreased neurodevelopment compared to kids who don't have HIV exposure. Next slide. And we had looked at this, and others have. Next animation. And next two. And have shown the same things in studies in Kenya, where children who had HIV exposure had poorer growth and poorer neurodevelopment, with modest changes compared to kids without these exposures. Next slide. So we were interested in the HOPE study to try and understand now, with current regimens where there's better viral suppression, whether these changes still exist and what happens long-term to kids who have these exposures in pregnancy. And so we conducted this study where we looked at 1,000 children with HIV exposure and 1,000 children without. In the blue, you can see the children with HIV exposure, and in the yellow, you can see the ones without. And we enrolled these children at 6 weeks of age and then followed them serially to look at their growth and neurodevelopment over a 3-year period. We're also interested to know long term if any of these exposures have impact. And that's a lot more difficult to study because starting to fund a study with 20-year follow-up is not practical. And so, next slide, we tried to build cross-sectional surveys of kids who are 3 to 6, 6 to 5 to 10, 7 to 10, 11 to 14, and 15 to 18 who had maternal HIV exposure at the time they were in utero, and look in those cross-sectional cohorts and compare them to children and adolescents without that exposure. Next slide. And we did a variety of assessments, and this one we can go quickly through the animations just to show that there were a lot of different tests that we did on these children just to understand their neurodevelopment and mental health, and their this was done over that whole period of time in a longitudinal and cross-sectional cohort. Next slide. And this was led by Dr. Irene Jaguna, and the details of this cohort are presented in BMG Open. Next slide. And initially, one of the things that was interesting to find in this cohort in Kenya at 7 different clinics with 2,000 children with and without HIV exposure is that the children living in homes with HIV exposure had differences in terms of just social factors. They had older mothers, often single parents, lower education, higher food insecurity, and some differences in patterns of breastfeeding. Almost all of them their mothers had started ART before pregnancy, and 73% of them were on dolutegravir regimens. So how did these children look compared to the kids without HIV exposure when we followed longitudinally? Next slide. We found initially, and this was led by Dr. Jill Neary and Maureen Kinge, there was no mortality difference between children with this HIV exposure and those without at 1 year. Next slide. We did find persistent growth differences where there was lower growth in children with HIV exposure, and this was led by Dr. Glass. Next slide. And we found that at 1 year, they had very similar neurodevelopment, but some gross motor differences at 2 years. This was led by Dr. Volterres. Next slide. So then we tried to look at these cross-sectional cohorts of older children and adolescents. And next slide. One of the things to keep in mind is recruiting 16 or 17-year-olds who had a parent or mother with HIV is difficult because it involves disclosure and some other social conditions sometimes, or trying to just have a screening without disclosing can be complicated. And so there's some challenges getting these older children and adolescents. The other thing to keep in mind is that children and adolescents who are older were exposed to differences in terms of the likelihood that their mother received ART before pregnancy, or that they got some of our new regimens. Next slide. But even in this group of older children, there were still growth deficits. Marian Aguiza looked at this and showed that there were height deficits in the older children between 3 and 10 years of age. Next slide. And looking at autism, in a larger cohort, Dr. Jaguna found that they had similar prevalence of autism spectrum disorder, but among the children with HIV exposure, those whose birth weight was lower had a higher risk of ASD, and those who breastfed or immediately cried after birth were less likely to have ASD. Next slide. So there are a variety of different things that we've looked at in the HOPE cohort, and you can see that for many things, children are similar to groups of children who don't have exposure to HIV or ART, but there were some things consistently seen in all the cohorts in terms of some worse outcomes in neurodevelopment. Next slide. So why would this be? What are the mechanisms? These children did not acquire HIV, but there still appear to be some differences. And it could be that there are immune differences, inflammation differences, differences in CMV. So in the MIND study, we're trying to look at those in detail and try and understand the role of drug regimens, whether the microbiome differs in these infants, whether the breast milk oligosaccharides or CMV infections and immune activation in mothers is different. And those are all part of the MIND study that will help us try and understand why these differences occur. Next slide. And one of the things that I think we're coming to recognize as a field is that there may be differences biologically that motivate some of the small differences that we're seeing between children with and without these exposures. But at the same time, there could also be social behavioral mechanistic pathways that influence these outcomes as well. And it's important to look at both of these, not just one of the roots. Next slide. So in the future, where do we go from now? I think it continues to be really important to follow longitudinally to understand what the differences are in neurodevelopment growth and in brain structure. Now there are some exciting developments with the possibility of looking at brain structure with novel MRIs that are portable, that are in many of these sites. The Gates Foundation has donated some of these to sites to understand brain development. And this can help us understand not only in this context, but in general, any determinants that might influence neurodevelopment and help us optimize neurodevelopment in children in general. Next slide. It's also important to do implementation science to try and understand how do you actually screen for children who might have needs in very busy setting. A lot of the tests that you saw on the slide before take a lot of time, and it's just not practical for a very busy clinic. And so there needs to be work to understand how to get a simple, feasible screening approach scaled up and integrated into a general health context, and then intervene and identify those who are at risk. And this is particularly important when I showed you that slide of places where 1 in 3 or 1 in 4 children may be at risk. Next slide. Ultimately, it's going to be important to understand what to do if there are differences. And the nurturing care framework that I've outlined here, provided by WHO, really gives us a framework to say, how do you really do the best job to optimize nutrition, caregiving, security, help explore and stimulate learning, and promote health in children as they grow. Next slide. So in summary, there are increasing numbers of children exposed to HIV who did not become infected. And this is estimated to be around 60 million children, and in some settings as high as 1 in 3 or 1 in 4 of the children in the population. And so it's very important to understand the health impact of this exposure and the exposure to drugs to try and understand what's happening and if there are interventions. It's also important to develop and implement effective screening and surveillance so that we can do our best possible job in optimizing outcomes in these children. And in this group of children, with or without differences, they provide us a lot of important learnings that helps us understand child development in general, not in any specific context, but the lessons learned for child development will be very extrapolable to settings outside of Africa, to the US, and to children in general. Next slide. So I'll end here and acknowledge a lot of people who have been involved, most importantly, the study participants and the people who led the studies in Kenya, as well as our funding partners. And I'll welcome any questions. Thank you.
What an interesting talk, and thank you for waking up early in Washington with us this morning, afternoon and evening for others. We do have a few moments. If there's a question, if you want to drop that in the chat, folks, please feel free to do that. I wanted to ask you, Grace, if you might be able to characterize what the impacts of the many cuts and terminations that we've seen in research and program is affecting these populations and communities that you're focusing on.
Yeah, excellent question. Unfortunately, the cuts have had large impact and will continue to have large impact on groups of people that we've been focusing on, particularly women and children in many of these settings. A lot of concern about maintaining good systems for good care, and a lot of that involves not only the drug supply chain and systems and clinics that we see, but also there are huge groups of peer supporters that support women in clinics like Mentor Mothers and adolescents supporting other adolescents. All those peer support groups and systems have risk of losing the great power that they had to improve outcomes for people in these settings. And so I think it's a very sad time. People are very resilient and developing solutions, but we really do need support to maintain the progress that we've had so far in doing what's been done to date.
I can only imagine. Do you have any examples on how some folks are sustaining their work even with all of these enormous challenges?
Well, I mean, people are very committed, as you know, and there's a great deal of advocacy. There are people who are working as volunteers who previously were paid that just don't give up on what their commitments were. And then trying to figure out alternative approaches and resources is the next step people are taking.
Yeah, indeed. And you're right. I mean, we're blessed. Our community is so passionate and cares so deeply and does so much volunteering and relies on such deep wells of resilience. Would that we would live in a world that didn't require such deep wells of resilience. But thank you. Thank goodness we have it. And thank you for the work you're doing and for your great talk today.
Thank you. And thank you for all you're doing. It's a great session.
You were number 71 in terms of speakers, and now we are on the last speaker. I am really excited to bring forward a colleague and friend from Sweet Home Chicago. Yay, Julia Rosebush from the University of Chicago. I'll let you, give your full bio, but such a pleasure to have you here and talking about HIV prevention, etc., with young people and teens. And this is a group I've certainly been really interested in over the last several years with our partners at Northwestern and Task Force Prevention and Community Services. We launched a Prep for Teens social marketing campaign, and it's been really great, such fun, and really looking forward to your talk, Julia. So without further ado, I'm going to turn it over to you.
Thank you so much, Jim, and thank you to AVAC and all of the people who have made this conference possible. I am truly honored and delighted to be here amongst so many colleagues, people who I look up to and admire in this field. This feels so good, and I am just so thrilled to be here. And I'm particularly thrilled to talk about a population that I feel is oftentimes neglected in the conversation around HIV treatment and prevention, STI treatment and prevention, and as medical director of Care to Prevent, the pediatric and adolescent HIV program at the University of Chicago. This is where I place my focus and my emphasis, and I really want to share with you today some of the work that we are doing, but also want to start off first with the basis for why it is that we do the work that we do. So again, thanks so much for the opportunity to showcase the great work being done here on Chicago's South Side. So, why is this important? I have people come up to me all the time and say, you do pediatric and adolescent HIV. Is this still a thing? Is there a need for this kind of work? To which I, of course, give a resounding yes, because we know that recent data tells us that youth who are between the ages of 13 to 24 make up almost 20% of persons in this country who are newly diagnosed with HIV. And for anyone out there who has had a teenager as a child or has worked with teens in some capacity, you know that there are unique challenges that they face, right? Some find it a struggle, but I actually find it as an area of opportunity and in a place where you can really intervene and change trajectories. We know that there are specific barriers to care that youth face that lead to suboptimal adherence to antiretroviral therapy. And when you compare them to their adult cohorts, they have poorer health outcomes. I think I would be remiss not to acknowledge the fact that there are glaring disparities when it comes to race, when it comes to new HIV diagnoses. And we know that Black and Hispanic youth are up to 17 times more likely to be diagnosed with HIV than their non-Hispanic white counterparts. And we do still see the highest rates of new diagnoses in males who have sex with males. And so when we think about advances in HIV care, right, I come back to, and I think I learned this from Jim a long time ago, right? There is a toolbox or a toolkit that we use, and we can look at advances in treatment and advances into prevention, because we need to think about not only treating those who are newly diagnosed, but really shifting our focus and thinking a lot more about prevention methods. How do we prevent HIV in the first place? And there are so many unique ways to think about doing this with youth communities. And so I'm going to just briefly mention the fact that while we've been talking about prevention in the form of biomedical pre-exposure prophylaxis or PrEP, youth were not, approved for this particular intervention until a colleague from UIC, Sybil Hosek and colleagues in 2018 did a landmark study in the Adolescent Trials Network that showed that this is safe, this is feasible. And in 2018, the FDA finally approved Truvada as PrEP for adolescents at risk for HIV. And so if we're looking at this timeline, right, and I get chills a little bit because I feel the same way about the way that we have thought about antiretroviral therapy in general. But we're going back now over a decade ago. In 2012, 18 plus, one pill once daily for HIV prevention for adults. 2 years later, the United States Public Health Service issued PrEP clinical practice guidelines that have been updated ever since. Again, in 2018, PrEP for adolescents is approved. The additional medication called Descovy, which is similar to Truvada but a little different, got an automatic approval for adolescents. And then we moved into this really interesting era that I love, which are long-acting injectables, with injectable cabotegravir approved in 2021. And just recently, as so many people watching this know, injectable lenacapavir was approved for prevention. And watching the way that this has been taken up in my clinical practice has been incredible. And I want to stress here to everybody at home that PrEP is for everyone. You know, there were misconceptions abounding that PrEP was only for males who have sex with males, or people who were in what we call serodiscordant partnerships, where one person had HIV, was living with HIV, and the other was not. But PrEP is for anyone who is sexually active, and in particularly in areas of high incidence and prevalence for HIV, I call on everyone here to really be talking to all patients who are sexually active about PrEP and whether or not it could be right for them. But the data shows that it is for everyone, including our teens. So how are we doing? What does PrEP prescription look like? And the CDC did have some data between 2019 and 2021 that shows us that while we are making incremental changes, we are not where we need to be, right? And we are also seeing glaring disparities back to who is receiving new diagnoses of HIV, right? This data will show you that individuals who are Black and or Hispanic are going to have higher rates of HIV. And this data will show you that we are not getting to those populations readily enough with PrEP to prevent those new infections. And if we look at this by sex at birth, we are also seeing that females are not being prescribed PrEP as often as male-identified folks at birth. And so when I talk about neglected populations, I could even go a little bit further into seeing that, you know, when you look at this data, right, we're thinking about young females who are sexually active and what are their risks. And this has actually been an increasing population who I've been doing a lot of work with clinically. And so we know that PrEP works. We know that this works. The data have shown us over the year that it works. And colleagues of mine led by Athena Curtis over at CDC looked at this in terms of PrEP provision 2018 to 2021. So those data were kind of across the board, but we're looking specifically now at PrEP in adolescents. And while we are increasing over the years, we're tending to get adolescents who are older in age, so not thinking about those 14, 15, 16-year-olds who are having sex, who are coming to me with newly diagnosed HIV infection. So over 88% of those prescribed in the year 2021 were in older adolescents and what we might even call young adults. And again, the data around sex at birth, males more frequently than females, is astounding here with close to 83%. And there are physician PrEP providers who can do this work, right? We don't need to have an infectious diseases background. All you need to do is read the guidelines, do some online modules for self-education. PrEP is something that every provider can do. Only 30% of those surveyed were pediatricians. And we know from other data that pediatricians need to step up and start to talk about sex and talk about PrEP with their patients and with families. And so when they looked at the overall data from this study, only roughly 15 to 20% of adolescents and young adults who could have benefited were actually prescribed. And you can imagine that there are many different things that were at play here, correct? Stigma, which is a topic unto itself, right? Fear of disclosure. That is one of the biggest things that I hear from my patients and also from fellow providers who have not been actively prescribing PrEP for youth. There are oftentimes cost and insurance concerns. Youth that I have spoken to about PrEP sometimes have a very low perceived risk, despite my thoughts otherwise. And again, education, right? What are we doing to ensure that communities are understanding what PrEP is, how it could benefit them? How do we educate parents and caregivers and families around discussing PrEP with their youth who are in their care? So what are our goals? We obviously, in order to end the HIV epidemic, need to eliminate we want to eliminate HIV. We want to prescribe PrEP. PrEP is one of the methods that we can utilize and implement in order to decrease morbidity, mortality, and again, another cost to individuals and society. And this is clearly what's under threat right now. We have, as an organization, had a big impact in terms of our ability to go out into community and to test. And I'll talk about that in just a moment. But we want to encourage providers to prescribe PrEP. We want to educate our patients. We want to provide adherence support, right? This is made better by long-acting injectables where there is no need for a daily pill. But for those who don't want an injection or who prefer a pill, they still need that adherence support. We want to give services, referrals for prevention and risk reduction. And we want to be able to monitor people in real-time settings for additional STIs and for level of risk to determine if PrEP remains something that they are eligible for or would benefit from. So I want to shine a brief light on the work that I do with an amazing team here at the University of Chicago. We are a small, what I would say, community-based organization nested within the larger University of Chicago. We are Care to Prevent. And as our tagline says, we are here for you. We are here for community. And we truly believe that wraparound services, support, and comprehensive care for youth is the way for us to move forward in terms of identifying youth who are at risk for HIV, who may already have HIV and need treatment and engagement in care, or who want to benefit from biomedical prevention. And so our guiding principles, again, focus on this comprehensive HIV treatment and prevention services. We want to focus in particular on individuals who identify as members of the LGBTQIA+ community, because we know that this is a group that is at higher risk than the background populations. We want them to understand that our services, our programs are built based on their feedback and input. We don't pretend to know what folks want. We go out into community and we ask. And we want to help all underrepresented youth communities on Chicago's South Side. And I'm so proud in this moment to focus on our community health and our outreach and prevention team, a small but mighty team that has looked at the data. You'll see the photograph on the right-hand side of the slide, or the graph on the right-hand side of the slide, that shows the areas in Chicago most impacted by HIV. And that is where our team goes. They go out to meet people where they are, not expecting them to come to the university setting for this work. So they are out in communities where high incidence of HIV and STI are. They are communicating and collaborating with community-based organizations out on our Comer Mobile Medical Unit, working at health fairs and sponsoring their own health fairs, and doing an incredible job at getting to people where they are in community. And this will reflect some of our data from the most recent couple of years. And you will see that there is a significant degree of GC, gonorrhea, and chlamydia positivity in the individuals who we test within South Side communities. And if you look over on the right-hand side of the slide, you are going to see that over the years, youth who are under the age of 25 have much higher rates of sexually transmitted infection than their adult counterparts. So we test everybody, but we do have this special focus on youth. And we have had the highest testing volume in the past year, with over 783 tests administered in community, 15% positivity rate for STI, and again, over 50% positivity rate among those under 25. Additionally, our team doesn't stop there. Our team thinks about harm reduction, right? This is how we're focused. And we see a lot of individuals who utilize substances. And so we also offer clean needles, Narcan testing supplies, fentanyl testing strips, and we've had over a 650% increase in just the last year for those particular supplies. We offer support groups. We offer case management. We have a peer mentorship program. We've started a newsletter, which I ask all of you to subscribe to hear what we're doing and what we're about. We've also partnered with our emergency department here at Comer Children's Hospital to roll out routine HIV screening and syphilis screening for our youth here on Chicago's South Side and beyond. That was an over 5-year endeavor, but we finally did it, and we are the only pediatric ED in the city of Chicago who is currently doing that work. And so just some take-home points that I want to focus on here before I close out is that, new diagnoses are still occurring and racial disparities exist. So yes, pediatric and adolescent HIV is still a thing. Routine screening is incredibly important when we think about prevention and new diagnoses. Wraparound services are absolutely key. And prescribe PrEP if you're a provider. Ask your medical provider about PrEP if you are not in the medical field but are curious about it. Think about long-acting injectable PrEP. It's been transformative in the over 20 patients in just the last month or two who I have started on injectable PrEP. And I really want to state, and this is a call to action, that federal funding supports this work. And federal funding is being jeopardized. Federal funding has impacted our program significantly and has curtailed the number of individuals that we have been able to test since January. So we really need to lean on each other, community partners, look for philanthropists and other ways to fund our work, but also continuing to petition our government for additional funding, letting them know how incredibly important this is. And I want to give a huge thank you to each and every one of my team members who are listed here, because without them, I could not do this work. I thank HRSA, CDPH, DIFA, Getting to Zero Illinois, AIDS Foundation, and Friend Health. And last but not least, our community partners, patients, and clients. We are indebted to you. Thank you for entrusting us with your care.
All that applause. Thank you, Julia. That was a beautiful talk. I'm very biased because I am a Chicago lover and defender through and through, and know your work well. It is really fantastic. We do have a question that came in from Meredith Green. Thank you for giving us that question, Meredith. And it's Dr. Rosebush. What are some of the main lessons you've learned in Chicago that could apply to other parts of the U.S. or even globally?
This is a really great question, because when I started in HIV medicine, I started in Botswana, and this was years and years and years ago, and came to the United States. And ever since, I have really been comparing and contrasting what those experiences have been like. But one of the things that I would say, and I would argue that I think many countries on the African continent do this incredibly well already, but is this important component of meeting people where they are and the outreach that is needed, sending people into community and not just setting up shop and expecting that individuals are going to come to you or even identify that they may need whatever it is that you are offering, right? So I think one of the things that I have learned and experienced sort of on both ends, right, both domestically and globally, is that it is incumbent upon us to be able to go out and provide outreach to communities in order to ensure education is there, to ensure testing is there, and to ensure that, we provide an avenue for them to engage in the services that are so desperately needed.
Absolutely beautifully said. And what a great way to sort of underscore your talk this morning. Thank you so much, Julia, for a great talk. Thank you for the work you're doing in Chicago. It's great to partner with you. And yay, teens. Teens can learn about PrEP and choose PrEP and are excited about PrEP, even if it's not for them at the moment. I think that's also important. we really focus on that it's a choice you can make at any time. The main thing is we want people to know about it, right? And to be able, so you can't make a choice if you don't know there is a choice to be made. So thank you so much.